Hello and welcome to Research Recap, where we dive a little deeper into the science being published at RPTH. My name is Luke Blunt, and I'm the Senior Marketing and Membership Manager at ISTH. Today, I'd like to introduce you to Dr. Daniel Steiner. Dr. Steiner is currently doing his PhD at the Medical University of Vienna under the supervision of Professor Chihan Ai. His research mainly focuses on the short and long-term consequences of VTE on vulnerable patient populations. He is particularly interested in patient-centered outcomes after VTE, such as functional limitations on mental health complications. He recently published a paper in RPTH titled Functional Limitations 3 and 12 Months After Venous Thromboembolism, a Cohort Study. For those joining us live, please leave your comments, which will be answered during the discussion. Dr. Steiner, we look forward to hearing your presentation.
Thank you very much for the introduction, Luke. I'm thrilled to be here, and it's amazing to have an opportunity to participate in an RPTH research recap. Elaborated on, I will talk about functional limitations and the work we did in Vienna in the last few years. And we published a paper on that in May 2024, and I'll spend the next 10 to 15 minutes just walking you all through the main results and takeaways from that paper. So venous thromboembolism is a common disease encompassing pulmonary embolism and deep vein thrombosis, and it's associated with a wide variety of potential outcomes. And historically, both research and clinics have mainly focused on binary clinical outcomes, such as mortality, recurrence, or bleeding. And while these are extremely relevant, we have seen kind of a paradigm shift in the last few years towards more society-level outcomes, but also very important patient-centered outcomes. Those include, for example, quality of life, psychosocial aspects, and also functional abilities. So how do patients function in their everyday life? And I will mainly focus on functional limitations today. And there are quite some tools to evaluate or assess these functional limitations. And one dedicated tool for functional limitations has been published and proposed by Eric Klock in 2019. It's called the Post-VT Functional Status Scale. This is an ordinal scale ranging from...
Daniel, sorry to interrupt. It
Worse.
looks like we're not seeing your full presentation here.
You're not seeing my presentation. Okay, that's not good. I'm sorry.
Oh, I see your mouse there. Oh, if you could blow it up, maybe that will. There it goes.
Will work like that.
Yes.
Okay, perfect. So I'll just show that slide once again. So we've seen the paradigm shift towards patient-centered outcomes in the last few years, quality of life, psychosocial aspects, but also functional abilities. And one tool to evaluate functional limitations in patients with venous thromboembolism has been proposed by Eric Klock in 2019, the so-called post-VTE functional status scale. The PVFS scale is an ordinal measure ranging from 0 to 4, with higher grades indicating more functional limitations. So, for example, a patient with a scale grade of 4 is someone who cannot live alone without any assistance from another person. A patient with a PVFS scale grade of 1 has some pain, symptoms, or anxiety, but is able to do every activities of the daily living without any limitations in those abilities. And this tool is intended for all patients with venous thromboembolism, so both these with pulmonary embolism and these with deep vein thrombosis. And it has been modeled after the modified Rankin scale, and is intended to capture the whole range of outcomes of functional limitations after VTE, and has also been designed to be included in clinical trials. In 2022, the PVFS scale has been proposed as one of the core instruments for patients with VTE. It has also been included in the communication from the ICH SCC subcommittee and is really one main outcome measure for patients with VTE, as functional limitations are both relevant to clinicians and to patients. And regarding research, it has been proposed as a key secondary outcome measure in clinical trials such as the HiPython trial or the SAFE SSPE trial. But quite interestingly, even though it has been recommended in all those consensus statements and included as a key secondary outcome in ongoing clinical trials, there hasn't been any data on the natural course of functional limitations in clinical practice or cohort studies. So the scale has never been applied to a cohort study before. And that's why we tried to fill that knowledge gap and aimed to describe functional limitations 3 and 12 months after venous thromboembolism in clinical practice and investigate the association of functional limitations with clinical characteristics, kind of to characterize risk factors for functional limitations. We utilized the Bach VTE study for that. The Bach VTE study is an ongoing prospective observational cohort study at the Medical University of Vienna, focusing on bleeding and long-term patient-centered outcomes in patients with VTE. And we started this study in 2020, and we're still recruiting patients, basically everyone with an acute, symptomatic, and objectively confirmed deep vein thrombosis of the lower legs and or pulmonary embolism. And we include patients within 21 days of diagnosis and then follow them up for up to 5 years. For the current analysis, we've included 307 patients. And to understand the results, we have to look a bit in the study schedule. So we include patients at the time of diagnosis. And then we assessed functional limitations with the PVFS scale after 3 months and after 12 months. And we also asked patients about their limitations at the time of inclusion, which is basically the time of diagnosis. We assessed clinical characteristics at that point in time, and then we retrospectively assessed self-reported limitations prior to VTE. This is a way, yes?
Sorry, let me jump in here 1 second. I'm not sure if we can see your slides, but I'm not sure if we're going through the ones that you were, now I can see it.
Now you can see it.
Yes, but for some reason when you were clicking through the, yeah.
So should I go like that?
We can see that now. Yeah, you can try presentation.
And can you see it now, Luke? Does it work like that?
When you go through, I'm not saying it go through, but for some reason, when you switched, right when we switched back, we got to see it now.
I can also stay like that if that's better.
We can go through it that way. Yep.
Maybe let's do it like that.
Okay.
So, okay, sorry for the technical issues.
No, sorry about that.
No worries. So, coming back to the study schedule, we assessed functional limitations after 3 months and after 12 months, and also asked patients about their limitations at the time of VTE diagnosis, so at the time of inclusion, and asked them about the limitations prior to VTE, which is a way with the PVFS scale to have kind of like a baseline value. At inclusion, we also assess clinical characteristics, which we then associated to functional limitations after 3 and 12 months. And importantly, as the Bach VTE study is mainly focused as a primary outcome on bleeding events, patients who discontinue anticoagulation are not observed further after 3 to 6 months. So at the 3-month follow-up, we kind of have the general VTE population, and at the 12-month, we only have those who remain on anticoagulation as a secondary prophylaxis. For the current analysis, we also excluded patients with active cancer, and we excluded those with pregnancy and in the postpartum state. And then we basically fitted 2 separate proportional odds logistic regression models, one for the 3 and 4, one for the 12-month follow-up, and calculated odds ratios and confidence intervals for the risk of being in a higher PVFS scale grade. So these odds ratios confer to the risk of having more functional limitations. And for continuous variables such as age and BMI, we allowed for nonlinear associations. Now we'll jump into the results. We've included 307 patients with a median age of 56 years, and about 42% were women. Median BMI was about 27.7 kilogram per square meters. About half of all patients had a pulmonary embolism. About 38% had a provoking factor for the VTE event. About a quarter of all patients a history of VTE before that very event. About a quarter of all patients had a history of cardiovascular or pulmonary disease, and about half of all patients were current or former smokers. And this alluvial plot now shows basically the main results. So first, we want to focus on the middle, which is kind of the functional limitations at the time of VTE diagnosis. So you can see in dark green those with no functional limitations at all, and in red those with the highest grade of functional limitations. And as you can appreciate, quite a lot of patients have slight, moderate, and severe functional limitations displayed in yellow, orange, and red. If we now go to the right side, we can see 3 months after the diagnosis, the patients improve. There are a lot more with no functional limitations than a lot less with severe or moderate functional limitations. So overall, we see an improvement compared to the time point of the diagnosis. However, still more than 50% had some degree of functional limitations indicated by a PVFS scale of 1 or above. And importantly, if you now look at the left side, you can see the baseline values, so the pre-VTE values of patients, the self-reported ones, and the majority of patients did not return to their pre-VTE functional status. So we can summarize, we can see an overall improvement from diagnosis to 3 months afterwards. However, still a large proportion of patients with functional limitations despite standard therapy, and patients did not return to their pre-VTE values. Female sex was significantly associated with functional limitations after 3 months, as well as BMI. So the higher the BMI, the higher the risk for having persistent functional limitations after 3 months. And those patients who reported more functional limitations at the time of diagnosis were also more likely to have functional limitations after 3 months. If we now look at the association between age and functional limitations at 3 months, we can see a general trend of higher functional limitations with higher age. Although we see kind of a minor drop at around 65 years of age, but overall, the older the patients were, the higher the risk of them to have persistent functional limitations. Now going back to the study schedule and considering the 12-month follow-up, just to keep in mind that the data I'll present now refers to patients who remained on anticoagulation, so patients on secondary prophylaxis. And this alluvial plot shows those patients, and we see quite a similar picture to the 3-month follow-up. So at baseline, we have quite some patients with slight, moderate, and also severe functional limitations. We see an improvement if we look at the 12-month follow-up. So over a period of 1 year, patients do improve, but still more than 50% had some degree of functional limitations. And overall, patients did not return to their pre-VTE functional status. And another thing we can appreciate if we compare the 12-month follow-up to the 3-month follow-up is that the relative numbers of the PVFS scale grades are roughly the same, which implies that after 3 months, patients basically reach a steady state and do not really improve from that time point on regarding their functional limitations. Now, risk factors for functional limitations after 12 months included female sex again. Then again, we had those patients who had a higher PVFS scale grade at diagnosis, also had a higher risk of functional limitations after 12 months. And for the 12-month outcome, a history of cardiovascular or pulmonary disease was also associated with more functional limitations. That basically leads me to my summary. So overall, we see an improvement in functional limitations 3 and 12 months after diagnosis. However, still more than 50% had some degree of functional limitations 3 and 12 months after diagnosis, despite having received standard therapy. And a large proportion of patients did not return to their pre-VTE functional status, implying that the VTE event is a life-changing event for patients. Clinical characteristics which were associated with functional limitations 3 and 12 months after diagnosis were female sex, higher age, higher BMI, history of cardiovascular or pulmonary disease, and functional limitations at the time of VTE diagnosis. These clinical characteristics we have identified could help to identify patients at risk of persisting functional limitations after VTE, preferably that should happen at a very early point of their disease course. However, if we're then able to identify those patients, we still really need strategies for improving functional limitations after VTE, either by preventing them or by treating them. And I think that's something we really should focus on, as functional limitations are really important to patients and clinicians as well. And we just have to keep in mind that those are really an important outcome measure. And with that, I'll conclude. I would like to thank my research group from Vienna under the supervision of Professor Jihan Ai, also our collaborators, including Benedikt Weber, Oliver Schlager, Stefano Barco, and Eric Klock. And I would like to thank you very much for attention. Again, apologize for the technical issues, and I'm happy to take any questions. Thank you very much.
Thank you so much for that presentation. I love that photo that you shared at the end. That was great. So I just want to remind everyone that you can submit comments and questions if you have any directly through the system, and we can answer those as they come in. In the meantime, I guess I can ask a couple questions. So Dr. Steiner, what was the most surprising finding from your research, if there was any?
I think, I've seen most of those patients in clinical practice, so it wasn't that surprising to me. But what still strikes me to that day is that we treat patients with anticoagulation. We basically do everything we're supposed to, but still those patients do not really recover. And they still report that they have like fatigue, that they have symptoms, that they do not function properly anymore in their in their social space with friends and family, and also in their job. And we really don't have a lot of strategies to work against that. So we cannot really offer patients a lot. We say we treat with anticoagulation, then we're basically done. But I think for the patients, we're not done at that point.
Yeah, so we got one question that came in, and they asked, how do the functional limitations evolve between the 3 and 12 months after a VTE event? So I guess the intermediate time there.
Yes, thank you very much for the question. So first of all, a very interesting question. Our study, unfortunately, wasn't really designed to evaluate that, since we had like 2 different cohorts at 3 and 12 months. However, it still looked into the sub-cohort of the patients at the 12-month follow-up, which were those who remained on anticoagulation. And what we can take away from that is that patients reach like a steady state after 3 months. So from 3 to 12 months, we do not see really a big difference in functional limitations anymore, which for me in turn means if we want to prevent functional limitations, we probably have to do that earlier. but after 3 to 12 months, the only option would be to try to treat them, kind of. But yeah, basically stay the same between 3 and 12 months.
And then another question for me. So what would be your next step, or for someone else even, to expand upon this research in order to give us even more insight?
I think there are two main questions we have to ask ourselves. Firstly, why do these functional limitations develop? Because right now it's like a clinical observation, but we do not really have any mechanistical explanation why this is happening. And what we see is certainly older patients, or like patients with more comorbidities, also those who have more functional limitations, but we also see young patients. We see patients not recovering sufficiently. So one main question is, what's the mechanism behind it? Is it hypercoagulability? Is it persistence of clots in the veins or in the pulmonary arteries? And the second main question is, how do we prevent or treat those functional limitations? And this includes both the physical and the psychological aspect. For example, considering rehabilitation, cardiopulmonary rehabilitations, or deep vein thrombosis rehabilitation, kind of with exercise training, but also the mental health aspect, which should not be forgotten when caring for patients with VT.
Yes. I see another question came in from Nicole. She asked, did you look for differences in functional limitations between those who had PE, DVT, or both?
Thank you very much for that question. It's very interesting. We did look into that. So we did a subgroup analysis of those with PE and those with DVT. And yeah, we had kind of a limited sample size for the subgroup analysis, so more uncertainty in the analysis, but overall similar results for patients with PE and patients with DVT. So not a big difference, which also struck me quite surprising, because one would suspect that maybe patients with PE are those who are more affected. But I guess that both events, both PE and both DVT, really affect patients' functional abilities, but maybe through different pathways. For PE might be dyspnea, for DVT it might be more like walking limitations, but overall no major difference between PE and DVT.
And then we'll do one more question, one from Anna. Were there any specific interventions or treatments during the study period that significantly impacted the recovery of functional abilities? For example, did you compare lysis versus no lysis?
Also a very interesting question. So for pulmonary embolism, we must acknowledge that our cohort is an observational cohort, so we really were not able to include a lot of patients with high-risk PE. So patients undergoing lysis. Also intermediate high-risk PE is a limited number in our cohort. So unfortunately, we cannot look into that specific treatment if those patients recover better than those without lysis. And for DVT, we have basically the same problem. We have some interventional venous therapies at our center, but the numbers are quite limited, so we were not able to analyze that.
Great. Well, I want to thank you once again for presenting this research. I think it's a very interesting topic, and I hope everyone reads the article at rpthjournal.org. I want to thank everyone else for joining and for submitting your questions. Again, please follow us on social media, on X/Twitter, Blue Sky, Facebook, LinkedIn, everywhere you get your social media, and you'll get the latest updates. Again, thank you so much, Dr. Steiner.
Thank you very much for having me
in RPTH again.
Yes, thank you so much, and thanks to the audience. Sorry for the technical issues, and if anybody wants to discuss this some more or wants to collaborate on something, please feel free to contact me directly.
Thank you.
Thank you.